Hi, my name is Dr. Hussein Hadi from Department of Pathology and Forensic Medicine at Mustansiriya University. In this series of 4 lectures, I will try to outline the endocrine system from the pathological point of view. At the end of last lecture, I started to talk about the major subtypes of thyroid carcinoma, namely the papillary carcinoma and follicular carcinoma. Today, I will try to cover the other subtypes of thyroid carcinoma, which are the anaplastic undifferentiated carcinoma and medullary carcinoma. Then after, I will move to the parathyroid gland and will try to outline the hyperparathyroidism and hypoparathyroidism. And hopefully, I will talk about the disorders that will affect the adrenal cortex at the end of the lecture. To begin with, I will start with anaplastic carcinoma. Anaplastic carcinoma are undifferentiated tumors of the thyroid follicular epithelium, accounting for less than 5% of thyroid tumors. They are aggressive with a mortality rate approaching 100%. Patients with anaplastic carcinoma are older than those with other types of thyroid cancer, with a mean age of 65 years. For the morphology, they manifest as bulky masses that typically grow rapidly beyond the thyroid capsule into adjacent neck structures. Microscopically, these neoplasms are composed of highly anaplastic cells, which may be large and pleomorphic or spindle-shaped, and in some cases, mixture of the two cell types. Foci of papillary or follicular differentiation may be present in some tumors. Clinical features: anaplastic carcinomas grow with wild abandon despite therapy. Metastases to distant sites are common, but in most cases, death occurs in less than 1 year as a result of aggressive local growth and compromise of vital structures in the neck. The next thyroid carcinoma is called the medullary carcinoma. They are neuroendocrine tumors derived from the parafollicular cells or C cells of the thyroid. Like normal C cells, medullary carcinomas secrete calcitonin. Measurement of it is important for diagnosis and postoperative follow-up. In some cases, tumor cells elaborate other polypeptide hormones, for example somatostatin, serotonin, and vasoactive intestinal peptide. Medullary carcinomas arise sporadically in 70% of cases. The remaining 30% are familial, occurring in the setting of multiple endocrine neoplasia syndrome 2A or 2B, or familial medullary thyroid carcinoma without an associated multiple endocrine neoplasia syndrome. As you can notice in this table, both familial and sporadic medullary forms are associated with gain of function, driver mutations in the RAT receptor tyrosine kinase. Sporadic as well as familial cases without an associated multiple endocrine neoplasia syndrome occur in adults 5th to 6th decades. The cases associated with men 2A or men 2B, by contrast, tend to occur in younger patients, including children. For the morphology, they may arise as a solitary nodule or may manifest as multiple lesions involving both lobes of the thyroid. This multicentricity is common in familial cases. Larger lesions often contain areas of necrosis and hemorrhage and may extend throughout the capsule of the thyroid. Microscopically, they are composed of polygonal to spindle-shaped cells, which may form nests, trabeculae, and even follicles. Amyloid deposits derived from altered calcitonin molecules are present in the adjacent stroma and are a distinctive feature. For the familial medullary carcinomas, they are characterized by the presence of multicentric C-cell hyperplasia in surrounding thyroid parenchyma, a feature usually absent in sporadic lesions. This figure is for the medullary carcinoma of thyroid gland. These tumors typically contain amyloid, visible here as homogeneous extracellular material derived from calcitonin molecules secreted by neoplastic cells. Clinically, in sporadic cases, medullary carcinoma manifests most often as a mass in the neck, sometimes associated with compression effects such as dysphagia or hoarseness. In some instances, the initial manifestations are caused by the secretion of a peptide hormone, for example, diarrhea caused by the secretion of vasoactive intestinal peptide. Screening of patients relative for elevated calcitonin levels or RET mutation permits early detection of tumors in familial cases. All members of multiple endocrine neoplasia 2 kindreds carrying RET mutations are offered prophylactic thyroidectomies to prevent the development of medullary carcinomas. Often, the only histologic finding in the resected thyroid of these asymptomatic carriers is the presence of C-cell hyperplasia or small, less than 1 cm micromedullary carcinomas. I already finished talking about the thyroid dysfunctions, including the hyperthyroidism, hypothyroidism, autoimmune thyroid diseases, diffuse and multinodular goiters, as well as the thyroid neoplasms. Now I will move to talk about the parathyroid glands and their disorders, namely the hyperparathyroidism and hypoparathyroidism. We know that the parathyroid glands are derived developmentally from pharyngeal pouches that also give rise to thymus. As you can see in the left image, they are most commonly located in close proximity to upper and lower poles of each thyroid lobe. Most of the gland is composed of chief cells, as you can notice in the right images. These chief cells have secretory granules containing parathyroid hormone. In addition, you could also see the oxyphil cells throughout the normal parathyroid, either singly or in small clusters. They are slightly larger than the chief cells, have acidophilic cytoplasm, and are tightly packed with mitochondria. The parathyroid glands are key regulators of calcium homeostasis. The activity of the parathyroid glands is controlled by the level of free ionized calcium in the blood. Normally, decreased levels of free calcium stimulate the synthesis and secretion of parathyroid hormone, which has the following effects on its target tissues, the kidney and the bones. The first effect on the kidney is increased renal tubular reabsorption of calcium. In addition, there is an increased urinary phosphate excretion, thereby lowering serum phosphate levels, since phosphate binds to ionized calcium. In addition, there is an increased conversion of vitamin D to its active dihydroxy form in the kidneys, which in turn augments gastrointestinal calcium absorption. The effect on the bone, there is an enhanced osteoclastic activity, that means the bone resorption, thus releasing ionized calcium, mediated indirectly by promoting the differentiation of osteoclastic progenitor cells into mature osteoclasts. The net result of these activities is an increase in the level of free calcium in the blood, which inhibit parathyroid hormone secretion from chief cells. Parathyroid dysfunction can cause an overproduction of the parathyroid hormones, and this terms the hyperparathyroidism. Now I will start to talk about the hyperparathyroidism in more details. The hyperparathyroidism occurs in two major forms, as primary and secondary, and less commonly as tertiary hyperparathyroidism. Primary hyperparathyroidism represents an autonomous spontaneous overproduction of parathyroid hormone, while as you can see in this table, the latter two conditions, which is the secondary and tertiary hyperparathyroidism, typically occur as secondary phenomenon in patients with chronic renal insufficiency. For the primary hyperparathyroidism, it is a common endocrine disorder and an important cause of hypercalcemia. The frequency of occurrence of the various parathyroid lesions underlying primary hyperparathyroidism is as follows. The great majority is called the adenoma, which accounts for 85% to 95% of cases. Next is the primary hyperplasia, which is either diffuse or nodular, which accounts for 5 to 10%, and rarely the parathyroid carcinoma, which accounts for only 1% of cases. For the pathogenesis, abnormalities in two genes are commonly associated with parathyroid tumors. First is the cyclin D1 gene rearrangements, and the other is MEN1 mutations. The cyclin D1 is a positive regulator of the cell cycle. These elements drive abnormal expression of cyclin D1 in parathyroid hormone producing cells, leading to increased proliferation of these cells. Cyclin D1 is overexpressed in about 40% of parathyroid adenomas, indicating existence of additional mechanisms that lead to its dysregulation. For the MEN1 mutations, it accounts for about 20 to 30% of sporadic parathyroid tumors, and they have mutations in both copies of the MEN1 tumor suppressor gene. Morphologically, include those in the parathyroid glands and in other organs affected by hypercalcemia. In 75 to 80% of cases, one of the parathyroid glands harbors a solitary adenoma, which is a well-circumscribed, soft, tan nodule invested by a delicate capsule. The parathyroid adenomas are confined to a single gland. The other glands are normal in size or somewhat shrinking as a result of feedback inhibition by elevated serum calcium. Microscopically, parathyroid adenomas are composed predominantly of chief cells, a rim of compressed non-neoplastic parathyroid tissue, generally separated by a fibrous capsule, often is visible at the edge of the adenoma. The chief cells of the adenoma are larger and show greater nuclear size variability than normal chief cells. In addition, cells with bizarre and pleomorphic nuclei are often seen within adenomas. This is so-called the endocrine atypia and must not be taken as a sign of malignancy. The mitotic figures are rare, and you should know that the adipose tissue is inconspicuous within adenomas. This figure is for the chief cell parathyroid adenoma. You could see in the left side microscopic image, which is taken at a low power view, a solitary hypercellular adenoma is delineated from the residual normal cellular gland on the upper right. In the right side microscopic image at high power detail shows minimal variation in nuclear size and occasional follicle formation. In both images, you could see the adipose tissue is inconspicuous within adenomas. The next is the morphological characteristic of parathyroid hyperplasia. It is typically a multiglandular process. In some cases, however, enlargement may be grossly apparent in only one or two glands, complicating the distinction between hyperplasia and adenoma. Microscopically, the most common pattern seen is that of chief cell hyperplasia in a diffuse or multinodular pattern. Less commonly, the constituent cells contain abundant clear cytoplasm as a consequence of the accumulation of glycogen, a condition designated water clear cell hyperplasia. Stromal fat is discrete within foci of hyperplasia. I talked about the morphological characteristic of parathyroid adenoma and parathyroid hyperplasia. The other is parathyroid carcinomas. They may be circumscribed lesions that are difficult to distinguish from adenomas, or they may be clearly invasive neoplasms. These tumors enlarge one parathyroid gland and consist of gray-white irregular masses. The cells usually are uniform and resemble normal parathyroid cells. They are arrayed in nodular or trabecular patterns. In addition, the tumor mass is usually enclosed by a dense fibrous capsule. Invasion of surrounding tissues and metastasis are the only definitive diagnostic criteria. There are other morphologic changes that could be seen in other organs, such as the skeletal changes, renal changes, and the metastatic calcification. So first is the skeletal changes, which include increased osteoclastic activity that results in erosion of bone matrix and mobilization of calcium salts, particularly in the metaphyses of long tubular bones. Bone resorption is accompanied by increased osteoblastic activity and the formation of a new bone trabeculae. In more severe cases, the cortex is grossly thinned and the bone marrow contains increased amounts of fibrous tissue accompanied by foci of hemorrhage and cysts. This is called the ostitis fibrosa cystica. Aggregates of osteoclast reactive joint cells and hemorrhagic debris occasionally form masses that may be mistaken for neoplasms. This is called the brown tumors of hyperparathyroidism. Next is renal changes, at which parathyroid hormone-induced hyperglycemia favors the formation of urinary tract stones, nephrolithiasis, as well as the calcification of renal interstitium and tubules called the nephrocalcinosis. The other morphological changes is called the metastatic calcification, secondary to hypercalcemia, seen in stomach, lungs, myocardium, and the blood vessels. Clinically, primary hyperparathyroidism usually is a disease of adults and is more common in women than in men, with a ratio of 4 to 1. The most common manifestation is an increase in serum ionized calcium. In fact, primary hyperparathyroidism is the most common cause of clinically silent hypercalcemia. Moreover, in the hypercalcemia caused by parathyroid hyperfunction, serum parathyroid hormone is inappropriately elevated, whereas serum parathyroid hormone is low to undetectable in those with hypercalcemia caused by non-parathyroid diseases, including malignancy, the osteolytic bone metastasis. Other laboratory findings include hypophosphatemia and increased urinary excretion of both calcium and phosphate. We should know that primary hyperparathyroidism traditionally has been associated with painful bones secondary to fractures of bones, renal stones with obstructive uropathy, abdominal gones, and psychic moans. Because serum calcium is now routinely assessed in most patients who need blood tests for unrelated condition, hyperparathyroidism is usually detected early in its course. Additional signs and symptoms that may be encountered in some cases, as shown in this table, include GI disturbances, for example, constipation, nausea, peptic ulcers, pancreatitis, and gallstones. CNS alterations could also be seen, include the depression, lethargy, and seizures. Neuromuscular abnormalities could also be seen in patients and presented with weakness and hypotonia. The other symptoms is polyuria and secondary polydipsia. The other major form is called secondary hyperparathyroidism. It is caused by chronic depression of serum calcium levels, most often as a result of renal failure, leading to compensatory overactivity of parathyroids. The mechanisms by which chronic renal failure induces secondary hyperparathyroidism are complex and not fully understood. Chronic renal insufficiency is associated with the following. First is decreased phosphate excretion, which in turn results in hyperphosphatemia. The elevated serum phosphate levels directly depress serum calcium levels. Secondly is loss of renal alpha-1 hydroxylase activity, which is required for the synthesis of the active form of vitamin D, reduces the intestinal absorption of calcium. It is important to know that these alterations cause chronic hypocalcemia, which stimulates the activity of the parathyroid glands. Morphologically, the parathyroid glands are hyperplastic. The degree of glandular enlargement is not necessarily symmetric. Microscopically, the hyperplastic glands contain an increased number of chief cells, or cells with more abundant clear cytoplasm, which is called the water clear cells, in a diffuse or multinodular distribution. In addition, fat cells are decreased in number. In regard of bone changes, they are similar to those seen in primary hyperparathyroidism. Metastatic calcification may also be seen in many tissues. The clinical manifestations are dominated by those related to chronic renal failure. In addition, bone abnormalities, which is called the renal osteodystrophy, and other changes associated with parathyroid hormone excess are in general less severe than those seen in primary hyperparathyroidism. The metastatic calcification of blood vessels could also occur. Occasionally may result in significant ischemic damage to skin and other organs. In a minority of patients, parathyroid activity may become autonomous and excessive, with resultant hypercalcemia, a process termed tertiary hyperparathyroidism. It is worth to know that the parathyroidectomy may be necessary to control the hyperparathyroidism in such patients. After the hyperparathyroidism, the other parathyroid gland disorders that we want to know is the hypoparathyroidism. Hypoparathyroidism is far less common than hyperparathyroidism. The major causes include the following. First is surgical ablation. It is unintentional removal of parathyroids during thyroidectomy or other surgical neck dissections. The second cause is congenital absence. Occurs in conjunction with thymic aplasia called the DiGeorge syndrome and cardiac defects, secondary to deletion on long arm of chromosome 22, region 1, band 1, subband 2. Thirdly is autoimmune hypoparathyroidism. It is a hereditary polyglandular deficiency syndrome arising from autoantibodies to multiple endocrine organs, including parathyroid, thyroid, adrenals, and pancreas. It is caused by mutations in the autoimmune regulator AIRE gene. The major clinical manifestations of hypoparathyroidism are secondary to hypocalcemia, which could be presented as acute cases or manifestations of chronic hypoparathyroidism. Acute cases manifest as increased neuromuscular irritability, for example, tingling, muscle spasms, and sustained carbopedial spasm or tetany. Cardiac arrhythmias could also occur, as well as increased intracranial pressure and seizures. For manifestations of chronic hypoparathyroidism, these include cataracts, calcification of the cerebral basal ganglia, and dental abnormalities. The last part of this presentation, I will try to give an overview for the adrenal glands, which compose of an adrenal cortex and an adrenal medulla, and I will start to talk about the adrenocortical hyperfunction. The adrenal glands are paired endocrine organs consisting of cortex and medulla, which differ in their development, structure, and function. As you can see in this figure, the cortex consists of 3 layers of distinct cell types. Beneath the capsule of the adrenal gland is the narrow layer of zona glomerulosa. Then the intervening is the broad zona fasciculata, makes up about 75% of the total cortex, and inward is the narrow zona reticularis, abuts the medulla. The adrenal cortex synthesizes three different types of steroids, including first the mineralocorticoids, which is the most important, being aldosterone generating in zona glomerulosa. There is also the glucocorticoids, principally cortisol, which is synthesized primarily in the zona fasciculata with a small contribution from the zona reticularis. And finally is the sex steroids, namely the estrogen and androgens, produced largely in the zona reticularis. The adrenal glands also consist of the medulla, which is composed of chromaffin cells that synthesize and secrete catecholamines, mainly the epinephrine. The adrenocortical hyperfunction, hyperadrenalism. As indicated in this figure, there are three distinctive hyperadrenal clinical syndromes, each caused by abnormal production of one or more of the hormones produced by the three layers of the cortex, and these are: first, Cushing syndrome, characterized by an excess of cortisol. Secondly is the hyperaldosteronism, caused by an excess of mineralocorticoid. And finally is the adrenogenital or virilizing syndromes, caused by an excess of androgens. In this lecture, I'll try to cover the Cushing syndrome, and hopefully the rest will be outlined in the next lecture. Cushing syndrome, hypercortisolism. It is caused by elevated glucocorticoid levels. In clinical practice, the majority of Cushing syndrome cases are the result of administration of exogenous glucocorticoids, which is iatrogenic. The remaining are endogenous, and the three most common disorders are as follows. First, as indicated in the upper left image, the primary hypothalamic pituitary diseases associated with hypersecretion of ACTH, also known as Cushing disease. Next, in the lower left image, there is secretion of ectopic ACTH by non-pituitary neoplasms, and in this case is the lung cancer. The other is the primary adrenocortical neoplasms, which is seen in the upper right image, which is either adenoma or carcinoma, and rarely primary cortical hyperplasia. It is important to note in the iatrogenic Cushing syndrome, there is an adrenal atrophy, whereas in the endogenous forms, there is an adrenal hyperplasia, except for the primary adrenocortical neoplasms. This table illustrates the endogenous forms of Cushing syndrome, and these are: first, the Cushing disease. In Cushing disease, the adrenal glands show variable degrees of bilateral nodular cortical hyperplasia, which is ACTH dependent Cushing syndrome, which is in turn responsible for the hypercortisolism. The secretion of ectopic ACTH by non-pituitary tumors accounts for about 10% of cases of Cushing syndrome. In many instances, the responsible tumor is a small cell carcinoma of lung, carcinoids, medullary carcinomas of the thyroid, and pancreatic neuroendocrine tumors. As in pituitary variant, adrenal glands undergo bilateral cortical hyperplasia secondary to elevated ACTH. The primary adrenal neoplasms, including adrenal adenoma and carcinoma, and rarely primary cortical hyperplasia, are responsible for about 15 to 20% of endogenous Cushing syndrome, also designated ACTH-independent Cushing syndrome because adrenals function autonomously. The biochemical hallmark of adrenal Cushing syndrome is elevated levels of cortisol and low serum levels of ACTH. There are two variants of this entity. The first presents as macronodules of varying sizes, typically less than 3 cm in diameter, and the second as micronodules, which is between 1 to 3 mm. The morphologic changes in adrenal glands depend on the cause of the hypercortisolism and include first, cortical atrophy, secondly is the diffuse hyperplasia. In addition, there is a macronodular or micronodular hyperplasia or an adenoma or carcinoma. In exogenous glucocorticoids, suppression of endogenous ACTH results in bilateral cortical atrophy due to a lack of stimulation of the zona fasciculata and zona reticularis by the ACTH. The zona glomerulosa is of a normal thickness. In endogenous hypercortisolism, the adrenals either are hyperplastic or contain a cortical neoplasm. In regard of diffuse hyperplasia, it is found in patients with ACTH-dependent Cushing syndrome. Both glands are enlarged. The adrenal cortex is diffusely thickened and variably nodular. The yellow color of the glands derives from the presence of lipid-rich cells, which appear vacuolated under the microscope. In primary cortical hyperplasia, cortex is replaced almost entirely by macronodules or darkly pigmented micronodules. The pigment is believed to be lipofuscin, a wear and tear pigment. This figure is for the primary adrenocortical hyperplasia, and grossly you could see the prominent pigmented nodules in the adrenal gland. Microscopically, the nodules are composed of cells containing lipofuscin pigment, seen in the right part of the field. For the functional adenomas or carcinomas, both the benign and malignant lesions are more common in women in their 30s to 50s. Adrenocortical adenomas are yellow tumors surrounded by thin or well-developed capsules. On microscopic examination, they are composed of cells similar to those encountered in the normal zona fasciculata. We should know that the carcinomas associated with Cushing syndrome, by contrast, tend to be larger than the adenomas. These tumors are non-encapsulated masses, having all of the anaplastic characteristics of cancer. With functioning adenomas and carcinomas, the adjacent adrenal cortex and that of the contralateral adrenal gland are atrophic as a result of suppression of endogenous ACTH by high cortisol levels. This figure shows the adrenocortical adenoma. The adenoma is distinguished from nodular hyperplasia by its solitary, circumscribed nature. Microscopically, the neoplastic cells are vacuolated because of the presence of intracytoplasmic lipid. In addition, there is a mild nuclear pleomorphism. This table illustrates the clinical features of Cushing syndrome. It is important to know that the signs and symptoms represent and exaggeration of the non-actions of glucocorticoids. Early manifestations of Cushing's syndrome include hypertension and weight gain. With time, the more characteristic centripetal redistribution of adipose tissue becomes apparent, with resultant truncal obesity, moon faces, and accumulation of fat in the posterior neck and back, and this is called the buffalo hump. In addition, hypercortisolism causes selective atrophy of fast twitch type 2 myofibers, with resultant decreased muscle mass and proximal limb weakness. The glucocorticoids could induce gluconeogenesis and inhibit the uptake of glucose by cells, resulting in secondary diabetes with its attendant hyperglycemia, glucosuria, and polydipsia. The catabolic effects of insulin resistance on protein causes loss of collagen. Thus, the skin is thin, fragile, and easily bruised. Cutaneous striae are particularly common in the abdominal area. The cortisol has diverse effects on calcium metabolism that lead to resorption of bone, which results in the development of osteoporosis with the consequent susceptibility to fractures. Moreover, because glucocorticoids suppress the immunity response, patients with Cushing's syndrome also are at increased risk for a variety of infections. Additional manifestations include hirsutism and menstrual abnormalities, as well as a number of psychiatric symptoms, including mood swinging, depression, and frank psychosis. It is very important to know that the extra-adrenal Cushing's syndrome caused by pituitary or ectopic ACTH secretion usually is associated with increased skin pigmentation secondary to melanocyte stimulating activity in the ACTH precursor molecule. This figure is for the patient with Cushing's syndrome, with the characteristic features including central obesity, moon faces, and abdominal striae. Finally, it is worth to know that in pituitary and ectopic Cushing's syndrome, ACTH levels are elevated. In contrast, ACTH levels are low in Cushing's syndrome secondary to adrenal tumors. These are some suggested readings for the primary hyperparathyroidism as well as Cushing's syndrome. Hopefully you will find it useful for you. Thank you.